All right, good morning. Okay, so this is going to be a little bit different than what we've experienced so far. We're getting into the first of two interactive case presentations for today. So this will be a case of an unstable patient with a penetrating infraclavicular gunshot wound. It's a little bit redundant. I didn't realize that. It's a gunshot wound. Okay, no disclosures. So there'll be opportunity to give your opinion, some multiple choice questions. There'll be about 5 of them through the presentation. There's 2 ways to deal with this. You can download the Poll Everywhere app if you haven't already, and the username's there, and you click on Join the Poll. Otherwise, you'll be able to just text your choices to certain text numbers, which I'll show you when we get to them. Okay, so gunshot wound to the left chest. So I'll read you this pre-hospital report. So on arrival, found an adult male lying supine on the floor with Phoenix police performing compressions on patient. Patient had a self-inflicted gunshot wound to the left chest with exit to posterior left shoulder. Patient states it was a 45. It's kind of interesting that the patient's talking. But as it said, patient's condition got better en route to the hospital. Patient taken advanced life support to St. Joe's Trauma Center as an immediate via whatever unit took them. So, okay, so they come in, and that was the location of the 2 wounds. So it looks like a through and through gunshot wound. So we know it's a 35-year-old male. And the report is that he did get CPR for about 4 minutes and then had return of vitals. And that happened approximately 10 minutes prior to arrival. They had attempted to intubate him at the time as well without success. And they did get 2 IVs. So when we see the patient, he has a patent airway. He has decreased breath sounds on the left side. And those are his vitals there. Heart rate 106, respiratory rate 27, blood pressure 156 over 125 was the first pressure we got, and his GCS was 14. Okay, so this is the first of interactive questions. So what do you do next? So the number you want to text to is 22333, and then if you choose A, you want to type the number 418. 740, etc. So choices, we can intubate the patient now, we can put a left chest tube in, we can get a chest x-ray to see what's going on, can take a better look at those wounds, or we can get some more IV access going, maybe a central line. So I'll give you all an opportunity to choose, and then we'll see what the survey says. And how are we doing? Okay, so definitely the most popular choice was C so far. No takers for D or E, huh? Oh, there we go. Oh, no, some second thoughts? Okay. All right, let's go back. Okay, so this is what I chose to do, or what we chose to do. So we put a chest tube in and then got the patient intubated. In my mind, this patient, even though the vitals weren't horrible, this was an unstable patient based on the wound, the history, and just my general gestalt. And so in principle, if you suspect a tension pneumothorax or a massive hemothorax, you don't necessarily want to wait for x-ray confirmation. There's a general rule in trauma, the cooler the x-ray, the less likely you should be looking at it. That's true most of the time. And if you intubate prior to decompressing the chest, you risk the patient decompensating from the induction agents and then the positive pressure from the ventilator once you get them intubated. So, did the patient have a pneumothorax or not? The resident thought that they got a little rush of air. I'm not really convinced the patient had a pneumothorax. You can see on the chest x-ray it looked pretty clear. But we get them intubated and get that chest tube secured, and the vitals look like this now, which is a little bit more reflective of what was probably actually going on. So this patient's in shock, and then we start getting some bleeding from the wound. And of note, the patient also has no pulse on the left side. So we've got some options here. Can apply direct pressure, can place a Foley catheter in the wound and inflate the balloon for tamponade, do a Reboa, try and get a tourniquet on, give an IV bolus normal saline. All right, good. So people are listening to Dr. Jacobs' talk yesterday. We need to first apply direct pressure to stop the bleed, right? Okay. So we're really in the C of the ABCs here. We want to restore this patient's blood volume and stop their bleeding. So direct pressure was the first thing we did. Now this wound was a .45 caliber wound, so it was a pretty good size hole in the infraclavicular space. So we could, you could get a couple fingers in there, and that actually was effective. You can see in the picture that's the principle for trying to do a balloon catheter tamponade of these kinds of wounds. And we did try this because the downside of the direct pressure is somebody's got to keep their finger in there, and if you can achieve this with a device, then it frees up that person's hands. And occasionally this works really well. It did not in this case because the gunshot wound of the skin was just too big and the catheter just kept popping out, so we abandoned that quickly and went back to having somebody keep their fingers in the wound. And then we want to restore the patient's blood volume, so we initiated massive transfusion. And we pulled, for starters, 2 units of blood and 2 units of pre-thawed plasma from our trauma bay fridge, and then the blood bank started to prepare the massive transfusion cooler. All right, so what's the next move? Get some imaging, a CTA of the chest, figure out the characteristics of this vascular injury, call IR in to do an arteriogram and possibly stent the subclavian or axillary artery, start looking at the wound further in the trauma bay, open the patient's chest, or go to the operating room. All right, so it's a landslide for operating room. All right, and that's exactly what we did. So got the patient up to the operating room, positioned for this type of extensile infraclavicular exposure. And while doing that, while prepping the patient, we had somebody with a glove and 2 fingers on the wound so the patient wouldn't continue to bleed. But I think they probably were continuing to bleed. Anesthesia was getting in lines, and we got the blood coming. And then we have a blood pressure of 40. So not good. So now what? Try and get some clamps in the wound, stop this bleeding better than the fingers were doing. Open the chest via median sternotomy to obtain proximal control, or through a left thoracotomy to obtain proximal control. Try the Foley again. or try and do a left claviculectomy so you can get a clamp on the more proximal artery. All right, go ahead and vote. Okay, interesting. Sure. Can we show the options again? Okay, fairly, I don't remember what D was, but it's not popular. Oh, I think that was the Foley balloon. Right. All right. Okay, so this is what we did. We did a left lateral thoracotomy to obtain proximal control, which is, it always looks better in the pictures. Medical illustrators are optimists, but why I did this was, I was really concerned that this patient was going to arrest again, and so I felt that being in the chest would allow me quickly to get subclavian control proximally without having to try and dig around in the wound, and potentially if I have to start doing open chest compressions, we're there. Most of the time, though, for axillary artery injuries, which is what I thought we were dealing with given the location of the wounds, you can usually approach these with just doing an infraclavicular exposure and while an assistant's holding pressure. But this one was too big, too cavitary to really do that safely, and especially in a very unstable patient at this point. So that's why we chose to do this. Patient in extremis requires quick and definitive proximal control, and the exposure of choice for the left subclavian is through the left anterolateral thoracotomy, a high one, rather than a median sternotomy. Median sternotomy is great for the carotids or the right subclavian, but the left is relatively posterior and harder to get via that route. Okay, so we'll get to the details of the operation here. So as I said, we did the anterolateral thoracotomy first, and then, that time lots of blood products are going in the patient, and vitals are getting a lot better. So then we did an infraclavicular exposure. Normally, in a low velocity wound, you have to actually divide the pectoralis minor muscle to see the whole axillary artery. In this case, there was a lot of cavitation from this bullet, and so everything was kind of just hanging out there in the breeze, similar to what you can see in this picture. The axillary vein had been transected, so we ligated the ends. The artery was transected as well, so we got proximal and distal control with vascular clamps at that point, and then we were able to take our clamp off the subclavian that was hanging out of the chest. Excise the injured portion. Normally, it's kind of hard to get a gunshot wound to the artery with a complete transection back together primarily, but in this case, with a little bit of mobilization, it actually came together pretty easily. So we did a primary anastomosis, which I always try to aim for if possible. I think the long-term issues with that are a little better than putting a graft in, but often for this injury, you do have to put a graft in. We identified a brachial plexus injury. There was clearly one cord that had been transected. We were able to identify that proximal end and tag it with a proline suture for the neurosurgeons for the future repair that they might do or might not do. Could not identify the distal end. And then closed his wounds and packed his posterior shoulder wound. So post-operatively, he did well from the surgical point of view. Extubated approximately 36 hours after the operation. But then he got really difficult to deal with. Severe agitation, delirium, not long after the extubation. And, what I didn't appreciate on the front end, but when we looked back, because we generally get blood alcohols on as part of the routine trauma blood draws. Blood alcohol was 392. And, we also learned from his family at that point that this wasn't just an isolated episode of binge drinking, that he's a pretty regular daily drinker. So, we did the usual CWA, starting with the Ativan, and it just escalated from there. So we had him on a lot of benzos, not really working very well. So here's some options. What drug or cocktail would you prescribe next? Okay, so C was definitely haloperidol was the most popular choice. So we ended up kind of doing all the above, more or less in this order. So, he was pretty wild. We didn't want to have to reintubate him. We tried Precedex, dexmedetomidine, which helped somewhat. He got a kind of a boatload of Haldol in the end. Eventually made our way, I think, from Ativan to Valium to Librium, and just over the course of the next 48 hours, still very agitated and difficult to deal with. And then we added Phenobarb at the encouragement of one of our pharmacists, which is, not a drug that I grew up with using for alcohol withdrawal, but there's a recent evidence now that suggests that it can be quite complementary, particularly in patients who are benzo resistant, which I think this patient was. So that actually helped the most, and then we were able to eventually get this resolved and get him to the floor. He did seem encephalopathic, and we thought, well, he did have CPR pre-hospital. He was pretty hypotensive here. Maybe he has a little anoxic brain injury. But we did get him out of the hospital. Clinic follow-up, the encephalopathy had completely resolved, which I was pleased to see. Has some left-handed weakness, but it was a little better than it was since discharge, and follow-up for the brachial plexus injury had been arranged. So that was the case. Just a little bit about penetrating vascular injuries of the axilla, particularly to the axillary vein, artery, and brachial plexus. So the vein is injured approximately 60% of the time when you've got an arterial injury from a penetrating wound to the infraclavicular space. And in general, if it can be repaired with a simple lateral venorrhaphy, we do that, or we ligate it. It's really rare that we would take the time to do a complex venous repair in this setting. Brachial plexus injuries also occur with relative frequency in this setting, and depending on the wounding mechanism, you can see this 40 to 90% of the time. You'd imagine with a high-powered rifle, you're going to see it a lot. With a knife as the mechanism, it's going to be relatively infrequent. Certainly, if a knife wound does injure the brachial plexus, the time to fix that is now, either at the primary repair or within a couple days of the wounding. So early repair is recommended for stab wounds because they're relatively clean cuts to the nerve and they tolerate repair pretty well. But for gunshot wounds, we've learned over the years that doesn't work so well, and expected management is kind of the standard of care now with delayed exploration or repair maybe 6 weeks or so down the road. And so this patient will get an MRI, and we'll get some nerve conduction studies, et cetera, done by the neurosurgeons we have who have interest in peripheral nerve repairs. And then the artery itself, as I said earlier, when the artery is divided by a gunshot wound, you often require an interposition graft. So then you have to make a decision whether you're going to use vein, whether you're going to use a prosthetic, and there's pros and cons for both of those. But if you can get it together primarily without doing too much mobilization, because you don't want to devascularize the collaterals too much, because they can be really important in keeping the arm alive. Once in a while, like in this case, you can get it together with primary repair. There is a damage control option. It's becoming more and more popular, which would be temporary intravascular shunt. You can do that with a proprietary shunt, a carotid shunt. You can even do it with a small chest tube. For an axillary, you need a pediatric-sized chest tube. You just cut it. But in the civilian trauma, in this setting, when it's an isolated wound, it's pretty rare that you actually need to shunt these. But it's a good option. And then ligation has historically been described as an option as well for these. But from the data over the years, it's associated with an amputation rate of 9 to 43%. So it's not really an ideal option, and you probably, if you can't repair it, think about shunting, and then ligation would be your last option. And thank you. That's it.